Hi, everyone, and thanks for coming today. My name is Bridget Patterson, and I'm a third year in the college majoring in public policy and psychology. At the IOP, I'm involved in USHI Votes, trying to get all students registered and voting. We aim to provide resources and a community that reduces barriers to voting that students face. If you need any voting help or just want to connect with USHI Votes, follow us on Instagram and Facebook at USHI Votes or go to our website, ushivotes.com. It's my honor today to introduce Dr. Emily Landon, Associate Professor of Medicine and Executive Medical Director for Infection Prevention and Control at UChicago Medicine. She has been practicing medicine at UChicago for over 10 years and has been integral in UChicago's and the state of Illinois' response to the pandemic. In March, she spoke alongside Governor Pritzker and Mayor Lightfoot to explain the importance of staying home and wearing a mask during the pandemic. Today, Dr. Landon joins IOP Director David Axelrod to discuss how our university and how the city of Chicago are doing now in the coronavirus pandemic and what we can all do to keep our campus and community as healthy as possible. Without further delay, I give the floor to Dr. Emily Landon. Thank you for coming today.
Hey, Dr. Landon, good to see you. We scheduled this long before we knew what a momentous and disturbing day this would be, but I can't, before we get into where we are as a community and where we are as a country relative to the virus, I have to ask you about the President of the United States, because we learned overnight that he has now tested positive for COVID, as has his wife, the First Lady. And I'm wondering how you interpreted that news and what we should expect and what he should expect.
Well, unfortunately, I can't say that I'm surprised. He's been doing a lot of behaviors that I would put on the spectrum of pretty risky. Even with the everyday testing, we know that those tests are not perfect, and it is really not testing that prevents infections, it's masks and distance. And those are two things that he's not been super keen on for whatever reason. And so while I wasn't surprised, I was definitely unhappy to hear. It is not great news for anybody to have COVID. Every case of COVID means that there's still ongoing exposure of other people, more COVID going forward, and it's not great for an older man to have COVID. Men are at higher risk of having bad complications of COVID than women. People in his age group often have a risk of dying in the 5 to 10% range, maybe slightly under 5% if you're otherwise pretty healthy. And then they have a high risk of hospitalization and needing a sort of more supportive care in order to get over their illness. And this is not the time when we want to have the President of the United States, who's running for re-election, in the hospital or suffering from COVID. It's just really sad and not great for any of us.
Yeah, and there's no way to really know what the course of this will take. The President's doctors reported that he had mild symptoms this morning, fatigue, cold-like symptoms, but this particular infection takes a circuitous route, and it's hard to predict, isn't it?
It does. It's actually sort of really kind of delayed route of infection. So people often take about 5 to 6 days after they've been exposed to someone with COVID to show any symptoms, if they ever show symptoms. And then most people who end up in the hospital with COVID have been sick with symptoms of COVID for about a week before they even come into the hospital. So this isn't something where you get sick really quickly. It's where it builds up over time. So we won't know how severe his infection is for another week. And we don't know very much about his underlying medical conditions. We haven't had as much information about his health as we have about previous presidents. And even if he is as healthy as a healthy horse, that's not a guarantee, especially for people in his age group. He certainly is high risk.
Obviously there are indications of people, age, general health and so on. Are there other characteristics? Have we learned anything about who is more likely? Are there things about our individual makeup that make us more prone.
Yes, uncontrolled underlying medical conditions, especially those involving the heart, the lungs, certainly put us at higher risk. We know that the president has mild high blood pressure or hypertension. That is definitely a risk factor. We also know that he is overweight, and the more weight you carry, the more risk you seem to have with COVID. And then he is male and he is in his 70s. So there's no guarantees for the president. He's in a very precarious situation right now. And the timeline of this, you know, oftentimes when people are in the hospital for COVID, they can be in the hospital. Those that end up succumbing to the disease, which I hope we do not see in this situation, can take another couple of weeks after even getting into the hospital to get to that point. We do everything we can to help save people and protect people from the bad outcomes, but they can take a while to manifest themselves. And I think that's not great news, considering the short timeline we have before the election. That, you know, as you know, you mentioned earlier when we were speaking right before we joined the group here, that people are already voting.
Yeah, yeah. Let us turn to the general subject of the virus. We met in April like this. What have we learned since then?
A lot. So much.
What are the main lessons you've taken away here, and how can you deploy them?
So when we have good PPE or good enough personal protective equipment in hospitals, we are absolutely capable of protecting our healthcare workers from getting COVID from patients. And this is so important because COVID is mostly spread through our close contacts. When we have unprotected close contact. So we know it's air spread by droplets that come out of our mouths. Most infections are probably droplets within 6 feet or so of another human being that has COVID. Some aerosolization does happen in certain circumstances, and that can be made worse by poor ventilation, sort of augmented because those aerosols stay in the air and just sort of accumulate over time if there's not enough airflow, new fresh air coming in. So we know when COVID is at its highest risk. And honestly, caring for patients in the hospital is one of the highest risks. You've got people who are unprotected, they're not wearing masks, they're having all these procedures that can make even more COVID get into the air. And we are absolutely capable of protecting our healthcare workers. We have had maybe only 1 or 2 healthcare workers that we could even begin to think might have picked up COVID from a patient. And that was before we knew about what protective equipment was appropriately needing to be worn, and through not being able to identify COVID patients because of, you know, sort of testing issues. But now we know that as long as you wear the right protective equipment, you can have even close contact with someone that has COVID safely. And this is really important because it allows us to be able to get out of our homes. We were in a stay-at-home order the last time we spoke because we didn't know how to protect everyday people. We couldn't identify who had COVID. We knew that people were contagious before they had symptoms. Some people never had symptoms. We knew that we probably needed to do something with masks, but we had no idea how effective fabric masks would be in certain circumstances. We didn't have enough medical masks for people. So we've gotten a lot more information about how to protect each other. And having these contacts, going to the grocery store, ordering food, going to the park with friends, being able to get together in small groups with your family can all be made lower risk now because of what we've learned about protecting our healthcare workers. But the other thing we've learned, at least in my experience at the hospital, is that while healthcare workers are really great at wearing all their protective equipment and taking care when caring for patients, they often see each other as low risk, and that's where we've seen spread inside the hospital. Our healthcare workers are much more likely to get it from each other in a break room, in a back room, from activities outside of work, than they are from the patients. And so we need to shift our mindset about what our risk actually comes from. It's not from these big events where you have close contact with someone that has COVID. Obviously, if you're not protected, that would be a problem. But if you're protected, that's fine. It's these one-off, like sort of having lunch with someone that is, you know, that you don't know very well. That's not really the person that you would choose, like that you absolutely definitely want to have close contact with. That's where it's coming from.
How and masks presumably have been proven to be
Essential.
I mean, the basic things that you guys counseled in the beginning, masks, personal hygiene, washing hands frequently, those are still proven.
Yeah, the 3 Ws, as I like to say: wash your hands, wear a mask, and watch your distance. Those are the main things. Even, we have a lot more access to testing now, but even testing every single day for all the people around the president and the president himself did not prevent transmission, but masks would have done. And so I think we really need to adopt masks. Looking at them as a political item is ridiculous. They're no more political than the shirt I'm wearing. They are, which doesn't have any political sayings on it, and it's
yeah. Okay, I'll take. I'm glad you cleared that up.
Yeah.
Talk about the Chicago area. First of all, I should ask: are we? You see the reports of what's happening in Wisconsin.
Mm-hmm.
Half the country is now reporting increased levels of activity. You scientists have warned that the fall would bring an increase in the virus. Is this the spike that you feared? Is that what we're seeing now?
Oh, I think this is just the beginning, unfortunately. Unless we all sort of get on board and really cut back on the number of people that we have up close or unmasked contact with. That means groups inside, being up close with other people indoors, with a mask even. But having too many people crowded, and especially if the masks are off, or the number of close contacts you have. It's not about, I think a lot of people think to themselves, because of these gathering limits, they think, but I'm just having lunch with one person, or I'm just hanging out with 3 friends. And so it ends up being that you had close contact with one person on Monday, 3 people on Tuesday, 4 people on Wednesday, 2 people on Thursday. And then all of a sudden, you basically have had close contact with a huge group of people just over a longer time period. And I think we have to start seeing this as I like to say we need to curate our close contacts. And if we start doing that, we might be able to see a blunting of this curve. But I think this spike is going to be ongoing through to January, or until we start having a significant availability of effective vaccines. But even then, we're going to need masks and distance. And that seems to be the hang up here.
Yeah. When you say through January, what does that look like?
I think it's going to look, in some places, it's going to look a lot like the worst things that we saw in March and April, or July. And I think it's going to be really rough in some places. It's hard to know which places are going to be hit. It depends on the behavior and the beliefs of individuals. If you want to be able to have large scale events without masks, then you need to be able to, you have to do you need to be able to go to restaurants safely and responsibly. And if you want to be able to have the opportunity to go to restaurants safely and responsibly, then you have to be able to go to outdoor things, like with a few people, responsibly and safely. And if you want to be able to do those, then you need to be able to wear a mask and keep your distance in general when you leave the house, because each of these build on the others. And if there's still a part of the community that are not wearing their masks and keeping their distance, it all comes down to individual behavior. Then you're going to see these things spread. And the more you try and push for each rung up the ladder, it's just more and more people being exposed. So the reality is that these places that are having, widespread openings of, putting the economy back to normal, it's not putting the economy back to normal, it's putting public health back to normal. And public health is not the enemy of the economy. It's not public health or the economy. It's, if you don't have public health, then people don't feel safe to go outside. And you find that a big chunk of people are just removing themselves from society. And so but that's not going to protect them, because these other people that are out and about and doing all of these things, they're going to spread it to others. Just like what happened with the president. I mean, he can take all the precautions he wants, but if you continue to have up close contact with people that are high risk, you're going to get burned. And I think that we're going to see that happening over and over and over again in some of these places. Even Illinois has been extremely aggressive. Chicago has been very aggressive. I think there are many industries in Chicago who would say that we've been way too aggressive. I think we've done a pretty good job here, but I think we're still at risk for having a big spike and a big peak. I think that's tough.
Well, that was where I wanted to go, which is where we are here in this community. And they had, I think the mayor, the governor have been very aggressive. I know you've helped advise them, and yet you say we're still subject to a significant spike. I mean, will that look like what we saw in the spring?
I think that the governor and the mayor in Illinois and Chicago have the best interest of everyone at heart. And I don't think that they are afraid to act aggressively. They've proven it in the past. And I'm really hoping that they will be able to act quickly, and that they will choose to act quickly, and they will continue to be smart and lucky, which I think you need both in this pandemic. And I think we'll continue to be smart and lucky, and that will get us to a place where we won't see quite the same thing that we saw in Chicago in March and April. But there certainly are other parts of the world and the country that are not going to take those actions. And I think they're at risk for seeing exactly that. I'm hoping in Chicago that we'll be able to keep things relatively stable, but I would expect to see an up and down in both openings and closings, and in cases and deaths.
You talk about dining outside. That becomes a little difficult in Chicago in November and December and January, and there are a lot of places that we're beginning to see the fact that it's getting cold. People are spending more time indoors. That has to be one of the calculations that you're making here in terms of your projections.
Yeah, I don't think that we're going, the mayor allowed indoor dining to go up in its occupancy rates, and allowed bars that don't serve food to start seating people or start having opening their doors for a certain occupancy. In the past, when we did this in June, even though the weather was warm and people could choose outdoors, this I think led to a big spike in 18 to 29-year-olds. And I am concerned that we will see the same thing again. I think that it's really hard to sustain. I'm not a business person, but from what I've talked to these people that own these businesses, and from what I've heard, and this is largely hearsay, it's hard to sustain a business on 25% occupancy. So there's a big incentive to sort of fudge that number a bit, or sort of push it up a little bit. And I think that's really tough. I also don't know that 25% occupancy is safe. It depends on what the ventilation is in those places and how careful people are. And I just don't know if we know that about all of these things. So my prediction is that we're probably going to have to step back from that, and that there's not going to be a lot of indoor dining happening over the winter in Chicago. And I would hope that we would move as a state, as a country, to support some of these businesses that are clearly suffering more than others in this pandemic.
Yeah. We're obviously here at the University of Chicago. A lot of thought has been given every single day to how and when to reopen, and now we're here. The students are arriving and so on. Candidly, the history at universities around the country has been pretty checkered. A lot, maybe it's just high-profile cases, but several universities have run into trouble. How do we avoid that here?
Well, I think, first of all, it's important to note that there are a lot of I think it is largely high-profile problems that happened right around the time of opening. And some of that is because they had higher rates coming in than they expected. They didn't anticipate that people, the behavior piece is really hard to wrap your head around. I actually study that when I'm not doing pandemic things. Hard to remember those days, but that's what I study, healthcare provider behavior. And I think we incorporated that a lot more into our plans here. Our rate of positives coming in the door, so on arrival, was extremely low. And we have a great contact tracing. The community here is different. The community is smaller than a lot of these other places. And there are a lot of schools who are doing great. So this is important to remember. We only hear about the ones that are having horrible times. At the University of Chicago, we have a really strong plan that focuses on the fundamental behaviors of masking, distance, and washing hands, surface cleaning, that sort of thing, but also staying home when you're sick, early contact tracing, testing in a reliable and sort of reasonable way. I have definite concerns that frequent negative tests make people feel invincible, like they can just go out and do what they want. And so I think there's something to be said about that. And we also have—
Just ask you, how reliable are the tests?
well, some of them are better than others. The one that we're using, but I don't think, if we're going to test people, I want a good answer. So we're using the same kind of test that we use in the hospital for our students at the University of Chicago. That's a really great PCR, quantitative PCR test that tells us a lot of information that's very sensitive. What they're using in the White House is an Abbott test. I think it's not 100% clear to me that they've not changed, but I know that they have been at times using different Abbott tests that are, and this is not to say Abbott makes a great, really high sensitivity test, but the ones that they're using are rapid, they're sort of faster turnaround, and those all have sort of issues with their sensitivity. The saliva tests that are being used by many universities also have issues with sensitivity, which may be fine when you're using them as a screening test, because you don't need to get everybody every single time. But instead of testing people on a regular basis every couple of days, which has not been proven to actually prevent spread of COVID in populations like this, and maybe it will be. Some of those universities have tried, like UIUC. Maybe they will have evidence from this that it does prevent, and in which case then we will happily adopt it. But we've chosen to go, there's no one size fits all. We've chosen to go a slightly different route and use a highly sensitive test and just test the people that are sick, and then also test our dorm students and our athletes on a regular basis. And so far, it seems to be working. I mean, I can't disclose their preliminary information, but it's going pretty well. And the campus, people are following the rules and they're learning, and we're taking the approach of helping people understand about why they need to keep their contacts low instead of just,
It's a lot to ask of young people.
Yeah, it is.
But I hope listening to you, those who are with us, understand that this is it fundamentally, we have responsibilities to each other.
We do.
And we have to think of it in those terms. It's not just about preventing yourself from becoming ill, but it's preventing others from becoming ill. And if we're a community, we have to act like one.
Yeah, it's no different than traffic laws and airplane safety. It's something that we all buy into together, and I think that really is a big role in why universities decide to open, because other communities can survive in this pandemic. We've seen it happen in other countries, in parts of the United States. Chicago's doing pretty well, and it's part of the educational experience to learn how to be a part of a community like that. And it's just as important to get that message across as it is to do complex math or science or any of the other things that one would learn in their educational process.
The last question for me, and then I want to get to the questions of people who are queued up. I know we have a lot of folks who have a great deal of interest. Vaccines. There's been a lot said about vaccines. What is the reality of, let's just say that there is a vaccine by the end of this year. And I don't know what your level of confidence is, but there sure are a lot of people working on this. But let's assume that we arrive at that place. Then how long will it be before we can ease off some of these measures, or are we not going to be able to ease off some of these measures?
David, this is a great question, and I thank you for giving me the opportunity to clear some of this up. First of all, the vaccine development process is long, arduous, and is laden with a lot of red tape. And the president's sort of warp speed campaign aims to remove a lot of the bureaucratic red tape and move the manufacturing up concurrent with the testing process, so that if a vaccine is approved, it's ready to go. It's been made. And I think cutting those corners is smart. I think they're the right corners to cut. But when we start cutting corners in terms of shortening the duration of time that we need to check for safety or efficacy, then we're getting into territory where it's not a good idea. It's dangerous, right? Yeah. And it's not clear to me that we have stopped cutting corners in the right place. It I'm still waiting to see. Now, I'm not privy to the detailed information, no one is really, about how these vaccines are doing. The people that do that, though, are called the Data Safety Monitoring Boards. And these are people that are ethicists and experts in the fields, and they actually get to preview the blinded data on a regular basis for every trial to understand if there are too many safety events, they can stop the trial. If there are no safety events and lots of efficacy, they can stop the trial early for being good and say, this shouldn't be on trial, it should just be approved. Now, none of these DSMBs have stopped trials because they are overwhelmingly effective and definitely no safety events so far. But that's okay, that rarely happens. They have stopped the one AstraZeneca trial for the issue that the transverse myelitis, or the neurologic symptoms in one patient. And they restarted in the UK, but they haven't restarted in other parts of the world. So we know that these DSMBs are doing their job. And I've been on DSMBs before. It is a sacred job. It is important. And we have to rely on and trust these individuals. They will not refer or not allow a trial to go forward to a manufacturer unless the drug is in their opinion safe and effective, and they are sort of our stopgap responsibility. So I think it's actually going to be a little bit important for us to better understand who are on these boards and how, and without pressuring them, which I think is an issue, and if they have ties to the companies or financial issues that may make them want to push the buttons. So I think that's where we can expect to see. So there's other safety things in place. The president isn't just going to be able to say, I want a vaccine, this one looks good, let's do it. And that's important.
But my question is, let's assume that things operate as they are supposed to. Let's assume that they're not short-circuited for political reasons. I mean, I am concerned that the politicization of the process is going to make people more reluctant to use the vaccine. But let's assume everything goes as we hope it does, and by the end of the year we have a vaccine. My question to you is, what's the timeline from there? And when can we expect, we have students here, others who are wondering, when do we get back to normal?
It's going to be a bit. First of all, the distribution process for these vaccines is going to be really challenging. We're not going to have 300 million, actually 600 million is what we need, because most of the vaccines require 2 doses. Vaccine doses available the first day that they're EUA approved by the FDA. We're going to have like maybe 10 or 20 million. And then they're going to have to ramp up production, and that takes time. As we know from we're still having issues with reagents for testing. And so I think we're going to be seeing a slow trickle of vaccines, of probably multiple different vaccines that will succeed, hopefully, if we're lucky. And it's going to be really challenging. Some of the sort of leading vaccines right now need to be stored in a minus 80 Celsius freezer. And once they've been thawed to minus 20 degrees Celsius, they're only good for 5 days, some only good for 2 days, which is...
Transportation becomes an issue.
The distribution and refrigeration becomes a logistical nightmare. Yeah. So, and if you need to have 2 doses of the same vaccine, how are you going to getting those people, like you run a small clinic, right? You get like 10 doses. My experience, I did the vaccine distribution for the healthcare workers at the University of Chicago for H1N1 2009. And we would get, you don't just get 100,000 doses all at once. You get like 20 doses. And then the next day you get like 50 doses. Then you get like 10 doses. You have to figure out who's next to get in line to get it. And if they can't get it that day, then the next person can come in. And what if the person that needs to, then are you going to be able to save doses to give them their second dose? Probably not, because most people don't have minus 80 freezers in their clinics. So it gets really complicated.
Yeah, so so on the timeline, I mean, when do you think that we'll get to a place where 60-70% of Americans are vaccinated and we approximate something like herd immunity?
In a year. About a year from now, we should have adequate supply. I think that Robert Redfield was right about this. End of second quarter, third quarter of next year sounds about right to me. But I don't have a ton of inside information. But that's sort of what it, like if you add up what you think.
That's sort of a best case scenario on the theory that we do get it by the end of this year.
Yeah, that's right. And then these vaccines are not 100%. They're not going to be 100% effective. Right. The threshold for approval is 50% effective. So they're going to be great. They're going to be as good as distance, as good as better, not as good as masks probably, but as good as distance, and a big adjunct to the masks, right? So they're additive. You're creating a really great.
We're still going to be working at this a year from now.
Yeah.
Let me read some questions to you. I was hoping we could do them live. I guess we can't. But Nora, a Harris student, says, for people who live alone and see winter coming, what are the safest ways for us to maintain some sort of social contact with people? Are any pods, she says in quotes, truly safe? How do we minimize risk?
You can't make yourself zero risk, but everybody needs close contacts. Even college students need close contacts. And that part of what we're telling people at the University of Chicago is exactly what I would tell you, and you may be at University of Chicago. You should have some close contacts, but you need to choose those people wisely. And you need to have it be the same people over a long period of time. So it doesn't need to be that just those three or four people, fewer than 5 is what we're recommending, are not, they don't need to only be hanging out with you, but you just want to make sure that the people that you choose to be inside your bubble, right, are also not in a ton of other bubbles. So I would not pick someone who likes to go to bars a lot or who is hanging out, who has a ton of extra risks. But somebody who has 3 different friends and you're one of them is probably the best you're going to get. And that's what you can have plenty of other friends. They just need to be at arm's length or through a screen or with masks on, and that's fine. But I think for up close and unmasked contacts, you want to limit those, not just in a day, but over a 10-day period. We're saying over a rolling 10-day period, you should have about 5 or fewer.
Stephen, a Harris student, says, knowing what we know about airborne transmission dynamics, how do we square the loosening of restrictions on indoor dining and bars with the very real and present threat of super spreader events indoors? As Dr. Landon mentioned, proper ventilation is critical. What role should the city play in assessing factors like ventilation? And why is the messaging around the risks related to indoor dining and bars so haphazard?
I will tell you this. I don't agree with the plan to reopen bars and to expand restaurant occupancy right now. I don't. I think it's the wrong time. I don't think it's a good idea. But we don't all agree on everything. That doesn't mean that I think that the people who've made that decision are super irresponsible. I'm just very conservative about this. I think that the majority of spread happens by droplets. Aerosolization is part of the issue. Airborne, which is sort of like it stays in the room even after you leave for a long time, less an issue with COVID, and probably not a big issue with dining. However, if you are in a very small restaurant where there's not great ventilation, as the questioner mentions, that can be an issue. Even if somebody is in there, because you're in there for an hour, they could be without their mask eating, a long meal. So I think if you are higher risk, you should probably not be eating indoors at restaurants. Certainly, I do not do that. I've said this before publicly. I have rheumatoid arthritis and take medicines that lower my immune system, so I'm definitely not doing that. But I think that some people may choose that for themselves. I think you have to take that into account when you decide who your close contacts are going to be. If you are the kind of person who's going to take the risks of eating inside of restaurants, then you probably don't want to do that in the week or 2 leading up to when you go visit your 90-year-old grandmother. That's how you can balance it.
Maddie, I think from Harris, is going to ask her own question live. Is
Great.
That, there you are.
Hi, thank you. Thanks for being here. I'm Maddie Soskin, 2nd year at Harris, and I'm spending this quarter in Chicago. I know you spoke a little bit about this with the pod, Nora's question, but just wanted to ask you if you could talk a little bit about how to reconcile, especially given that we're going to be in this for the long haul and working on it for a year from now, the mental health aspects with the physical health aspects of this, and kind of how can we reconcile those 2 things?
Yeah, they're going to take a lot of extra effort this year. That's just how it's going to be. But I think one of the things that matters is that recommendation I'm making about 5 close contacts. That number can be expanded if the rate of infections goes down, and as vaccines come into play and the more people wear masks and keep distance, the more we can expand our close contacts, because the risk, it's a numbers game in an SIR model of epidemiology. And so you can increase your contacts that way. So I think most important thing to do in communities is to keep those contacts low in the beginning until we get our feet wet, especially at a place like a university. And then maybe we can think about expanding them. In the meantime, you've got to make sure you keep in touch with friends that are not your up close and unmasked friends. You can have tons of friends. You just need to be masked. You can go to a museum together wearing masks. You can do stuff together wearing masks and keeping distance. And so you've got to make those friends. You know, University of Chicago is actually developing a video game, or not a video game, like a multiplayer online game that will encourage people to be in teams and to be able to meet up in ways like sort of, they keep describing it to me as it's not like Pokemon Go. It's like different, but you can do quests with your team. I've been working with them on it. It's a great idea. It gives you good ideas and positive ideas about how to be with other people, both online and in real life, in a safe way. And we have to just keep looking for those things instead of lamenting the fact that we can't do what we did last year at this time, and expand our horizons about what we can do with other human beings and how we can connect with them. That's not necessarily, you know, bobbing for apples. Now, does anybody ever do that anymore? Bobbing for apples at a holiday party. I think the Halloween recommendations that came out from the city of Chicago are really good. I think trick-or-treating actually should be all right. Just trick-or-treat with your family, your close contacts already. Masks are a part of Halloween already, so let's embrace it and wear your, like, make it part of your costume. You know, you can be arm's length and deliver Halloween treats. You know, just wash your hands afterwards and eat them. You know, these are ways that we can experience our community. But I think Thanksgiving should be smaller. I think it has to be less, or everybody showing up at Thanksgiving needs to be really careful and do like a sort of self-isolation, self-quarantine in the week or two leading up to it, so that you're coming to the table quite literally with the least amount of risk you can. So I think, and physical health, I think it's time to get some cold weather gear for walking and running outside.
Yeah, well, that leads me to the next question from Barbara from the Medicine and Biological Sciences Medicine and Biological Sciences Development. Do you think it is safe to go to the gym without masks but keeping 6-foot distance, swim in an indoor pool with reserved lane, and one person to a lane?
Okay, gyms without masks, not a good idea. When you're exercising, what happens is that your minute ventilation increases. That's the amount of air that you're moving through your lungs every minute, and that air is pulling droplets with it. And so people have got to have source control in gyms. I think with masks, the jury is still out about how safe gyms are. It's going to depend a lot on the ventilation and how crowded they are. Swimming, I think, is actually an exception, though. Chlorine kills COVID easily, and most pools in gyms are really highly chlorinated. And especially if you can reserve a lane, then you know it's not going to be crowded. And I think that actually there's some pretty good evidence that swimming is not an increasing risk factor activity when it's done as an exercise. When it's a bunch of people playing Marco Polo, maybe not, but swimming in terms of lane swimming, I think I would feel pretty comfortable about that. But be really careful about, if you're going to a gym to do it, about wearing your mask in the locker room. And always, when you're around other people that do not have their masks on, they are making droplets and aerosols, and those can get into your eyes. We forget our eyes all the time, and this is a big risk. A new study out of China showed that people who wore glasses, in general, healthcare workers who wore glasses and did not work in COVID-specific areas, were half as likely to get COVID than people who didn't wear glasses. So and glasses don't even like protect you from aerosols. They're only getting the droplets because they're not safety glasses. They're not all the way around. So if you're in a gym, if you're around other people, public transportation, gym locker rooms, that sort of thing, where other people don't have a mask, you've got to keep your 6-foot distance, and you've got to be careful about your eyes, especially, even if you have your mask on.
You just made me feel better about wearing glasses.
I've been wearing mine. I've got mine over here. I wear them mostly for reading, but I've been wearing them a lot out and about, but not usually on.
Well, Doctor, let me just say that the best thing that we can do is rely on science and the information that you and other professionals have accumulated, and you communicate them so well and so directly that I know the city and our community has benefited from it, the university has benefited from it, and we're so grateful to you for sharing time with us, and we may call on you from time to time
Please do.
to come back, because this is obviously a matter of huge interest to everyone, and we as a community have a great stake in how we react to it. And to everybody who's listening, I hope if nothing else you'll take away from this that there are things that we can do. This is not out of our capacity to, we may not be able to defeat this thing without the help of a vaccine and without time, but we certainly can limit its spread, and that relies on all of us. So let us take what Dr. Landon has told us to heart, and look forward to the day when we can gather again, not on Zoom.
Yeah, well, thank you for having me. It's a pleasure and an honor to be here, especially to talk to you. I know your voice it looms large in the political world, so it's an honor to be here. And I know all of the students that are here today get a great teacher in you, and I'm happy to do whatever part I can, but it all comes down to individual behavior.
Well, I get great teachers in them as well, it turns out. So anyway, Doctor, thank you so much, and we will see you down the line.
Bye, everybody.